pointing out I got some feedback about the lack of knowledge on certain normal things that we expect in neurosurgery. So wanted to start with some of the basic stuff. One of the things that Ms. Peterson found out was that there's a lack of understanding of the Glasgow-Coma scale, and that is an important measure that we use in neurosurgery. I mean, it's more related to the assessment of, it's technically developed for the assessment of trauma patients. However, it's widely applied to many patients that are having alteration of their mental status and depressed mentation and things like that. So it's important to know about the Glasgow-Coma scale. So what are the parts of the Glasgow-Coma scale? We'll make it interactive today. What are the parts? There's 3 parts.
Eyes, voice, and motor.
Right. Eyes, voice, and motor. So these 3 parts are on a scale of, is that you probably answering me?
Probably.
These 3 parts are on a scale of 0 to 6. They don't all have 6 involved, but the motor score has up to 6 points. The voice score has up to 5 points. The eye score has up to 4 points, and for a total of 15, and 15 would be normal. So the Glasgow-Coma scale score is on a scale of 3, which is the minimum, to 15, which is the highest. 15 is all of us in the room here now. Awake, normal, talking, mostly making sense. And so that normal would be the 15. And for the purpose of this, I think it's just important to point out that severe brain injury would be considered anything 3, 4, 5, 6, 7. Then once you get to 8, 8 to 13 really pretty much is kind of moderate to moderately severe. It just depends on what's going on with the patient. It can be very dependent on the circumstances of the patient and things like that. So the T denotes that the patient's been intubated. So if you see a 3T, that means, of course, they're intubated. You can have a 3 without being intubated, but hopefully they're quickly becoming a T. So as this is used, usually it's used to help guide therapy through the ER in traumas and other patients. So for instance, the Glasgow-Coma score of 8 or less usually is working their way towards an intubation. So 14 would be a patient who's confused. They're otherwise awake and acting, moving everything to command and otherwise mostly normal, but maybe they just don't know where they are or why they're there or something like that. 13 is a little bit more confused, and going down from there, the parts of the motor score, following commands, localizing to pain, withdrawing from pain, decorticate posturing, decerebrate posturing, these are all increasing severities of brain injury from, you can think of the top of the brain down through the brainstem. So decerebrate posturing is a more severe injury that denotes a lower injury at the level of the brainstem, potentially. And so that's that. What questions do y'all have about Glasgow-Coma score?
Do you document that before surgery, after surgery? Where would the nurses see the previous documentation?
Well, it's not, can be used relative to surgeries, but it's, like I mentioned at first, technically designed to be, I mean, it was specifically designed for trauma patients, but it's widely used otherwise. I mean, so if we're talking an elective surgery, you wouldn't use that because patients are going to be a GCS of 15. If it is a trauma, then that would be on their assessment as the EMS is rolling in. Should be part of their initial assessment. It's part of the assessment through the course in the ER. It would be part of the assessment when arriving to the ward, to the unit, in a trauma patient. And, you know, as it relates to surgery, it's not as big a part as it relates to surgery, frankly. So that part, it would be more on the assessments, the moment-to-moment assessments of the patient. Does that answer your question?
Yeah, I was
Okay.
just curious if Irving, you were to find that at, and that was something that was stressed from level of care, from ER to, to surgery, and then the floor gets the information for when they go up to the floor.
From my purpose, it would be in the progress notes or a consultation note. For y'all's purpose, though, in Epic, I'm sure there's a place to record that specifically that I don't know about. But I'm sure it's part of it's in the neuro assessments that y'all can make.
It's the very first thing on the list.
Yeah, yeah, and even beyond that, it might even be appropriate to communicate each individual, not just a collective score, but the individual scores. So, especially in a patient that is posturing, for instance, it might be important to know because of what I mentioned, a change. It represents a different level of injury, depending on what type of posturing they're doing. So it can be important to denote they're a motor score of 2 or 3 or 4. 2, 3, or 4. I mean, 4 is withdrawing, and that's better. Still is part of the potentially a severe brain injury. So you might communicate those separate. I mean, you might communicate each individual. So their I score is 3. And what would that mean? If they had an I score of 3, that means what?
When you're talking to them.
Yeah, but otherwise they're just kind of closing their eyes, drifting in and out of sleep or lethargy or something like that. So it's sometimes appropriate to communicate these things. They've got a GCS I score of 2, 3, 1, whatever it is. Obviously, if they're intubated, then.
So I have a bit of a complicated question, but try and keep it as simple as possible. What would a normal course of GCSs might be? Let's say it's a TBI, fairly uncomplicated. How quickly would you anticipate a recovery? Like, let's say their GCS is 10 after the procedure's been done, they're up to the floor, but they're protecting their airway, so they're not intubated, they're not on sedation.
Mm-hmm.
Would you anticipate that GCS should improve as a group for each of the 3 components, or might you see it dip and then rebound? Like, what kind of those components might you really find the most value in?
Well, all 3 of them are pretty valuable as a fairly quick and accurate assessment of the patient as a whole. Like I mentioned, the individual parts, you're right, it is a little bit of a complicated question because it depends on what the nature of the injury is. If it's a gunshot wound to the head, it's going to be a lengthy course. They may be GCS 7 for weeks or months even. Diffuse axonal injury is something that doesn't denote a brain stem injury necessarily, although it can relate to that. But these are patients that their recovery varies widely from the time they present to the time they're starting to wake up. if they're intubated, so we had that patient in the ICU that had a brain injury that had DAI. She didn't have a surgical injury, but she had a pretty severe diffuse axonal injury, DAI. And so she was intubated, but not following commands, but was localizing briskly. So let's kind of work that out, for instance. So on a GCS scale. So if they're localizing, but not following commands, that is a 5 right there. If they're doing anything with their eyes, then that's a 7. And if they're intubated, then that's a 1 because they're not talking. They're 1T or whatever. So that's an 8 right there. So a patient who's localizing is kind of on the verge of being able to be extubated. And so that's where the trick lies is assessing that patient in a way that's practical about, the big picture and what they may need for, to protect them from pneumonias and other things like that. So usually you can extubate those patients, even if they're not following commands, but it kind of boils down to the critical care physician and what their level of comfort is. If they're not used to treating those patients, or if they're not comfortable with extubating a patient until they're following commands, then they'll be intubated until they're a GCS of 9, at least.
So in terms of communicating with you then, let's say in a case just like that, should they no longer be localizing but that function drops by another point? Is a single point drop worth notifying you over, or should it, give it and maybe a couple hours to see if it was just a small dip and see if they rebound?
Yeah, I mean, this is the nuance of caring for patients, part of the nuance of caring for patients. Technically, maybe it's only a 1-point dip in the Glasgow Coma Scale, but maybe there's other things in the vital signs and other stuff that are concerning you. Of course, you should call me or whomever, critical care doc or whatever you're seeing that might be concerning. Other things is everything could be stable, but patients, neurologic, neurosurgical or neurologic patients go up and down. They wax and wane. They can go from posturing to localizing to posturing, over time. And so I had an order in Georgia that was said if they have a dip of a GCS more than 2 points, 2-point dip in their GCS, notify the neurosurgeon. But, there's no strong rule there. If, say, it's a 1-point, or say it's just a vital sign change or something, or an ICP change if we're monitoring their ICP. And they don't necessarily change their GCS, but you're becoming concerned about other things. Certainly. I'm always available. I never get upset about calls.
So as a fun side question, kind of picking up on the nuances of it, from that ICP part, we're all trying to fold that into our practice that we already have. So an increase in ICP, would you anticipate decrease in GCS, or maybe an increase in that agitation, which might increase movements? You kind of get the question I'm asking.
Yeah, I do. The ICP does not necessarily correlate with the GCS, but it does correlate more with patient's level of activity, potentially. So as the patient is becoming more and more active, arousing, maybe they go from withdrawing only to localizing, and they're coughing and bucking the vent and all these kinds of things, you might see an increase in the ICP. That's always tough to judge, even for us because, is it an increase? And let's change it around a little bit, make it a little more difficult. Say they go from posturing, they go from decerebrate posturing to decorticate posturing, and they're having a lot more posturing activity. The activity itself and the restlessness against the ventilator or something like that can cause ICP to go up. So sometimes it's certainly been known to happen on many occasions that you see patients who are kind of fairly well on their course of their brain injury and they're having these spikes all the time, but it doesn't match the imaging, it doesn't match the way the patient behaves with vital signs and the way they're behaving with the ventilator and things like that. So you might take the ICP monitor out so as not to worry people. But and there's been more and more research done lately, more looking into, or revisiting, I should say, the use of ICP monitors, and there's some pretty good, with the imaging that we have nowadays, there's some pretty good correlation that you can, in basically following the patient with imaging and their clinical behavior without an ICP monitor. Now that's not, that's, every patient deserves their own, plan of care, through their course and stuff. So, and that's what I practice. For a long time, for instance, any time a patient, for a few decades after ICP monitoring became practiced, if a patient had a GCS less than 8, they got an ICP monitor. But that's a risk of a procedure that might not be necessary. There's plenty of patients who are less than GCS 8 who have normal ICPs the whole time. So then you've exposed the patient to the risk of a procedure unnecessarily. So with the quality of imaging that we have nowadays, it's been my practice, frankly, to follow imaging and clinical behavior of the patient before I feel like I need to put a ICP monitor in. And that kind of comes with experience a little bit. You can
Engineering, please dial the operator.
You get,
Engineering, please dial the operator.
in training you get exposure enough to the correlation between what the imaging looks like and what the ICP is, and then you kind of formulate your own plan. Now some doctors are always going to put an ICP monitor in. I think that it's pragmatic to treat the patient, all of the data that you have on the patient, and not be protocol driven necessarily. So I can count on one hand in the last 5 years how many times I put an ICP monitor in, and I can count on 2 hands how many times I needed to put an external ventricular drain. So it doesn't come up that often. Here, I expect it even less because, we're a level 3 trauma center, and I was at a busy, ACS level 2 trauma center, and we were the neurosurgical referral center for about 1 million people, and there were 3 neurosurgeons, so me being one of them, and it was pretty busy service, and yet I rarely felt like I had to do that, and had a lot of good outcomes. Had patients coming out of their DAI sooner than in residency, than I saw during residency and things like that. So depending on how you're treating the patient clinically is what dictates their course. And you take all the data together and take it all into account.
Very cool. So with assessing the patient and evaluating them, let's just assume they're here for whatever issue that is causing them to have a elevated ICP coming out of the surgery. They get to the floor. We're doing good neuro assessments, but what are some of those things that we can maybe hone in on, or what are some changes that should raise red flags early still a pretty general question, but.
Yeah, it's quite a general question.
Basically, it's how to correlate assessment findings with the ICP best. What are some of those real high-value items on a neuro assessment that you might look at?
Well, the ICP, you know, there's not going to be something to correlate to ICP. It's just another data point to follow.
Okay.
So you can have high ICP. You know, for instance, you have a high ICP in a patient who's waking up and starting to talk to you. So, and that's because, you know, they've got all these interventions and they're fighting the IV and the PICC line and ET tube. Maybe they've got an NG tube, and that's a big one, you know, to agitate patients. So I wouldn't say that there's something to follow to help guide ICP as much as it's just another data point to follow of clinical information that you're getting about the patient, kind of like the blood pressure, you know, and the heart rate. So now what the ICP is reflecting is the intracerebral pressure. So let's say the patient comes in who had a big brain tumor, and there's a circumstance in which during the course of resecting a big brain tumor that there's a process called occlusive hyperemia, where there's so much blood supply going into the tumor, and you're going and you're cutting off all that blood supply to take the tumor out. And what can happen is the patient, so even though you've taken the tumor out, the brain swells because you've got such a change in the blood flow into and out of what used to be a tumor. And so you can experience brain swelling. So there's a circumstance in which maybe you're doing a tumor and you see some brain swelling that is concerning to me. I might put an ICP monitor in at the end of that operation, for instance, and that would be something that we would follow. So part of the data points, I mean, just think of it as another vital sign, really. So for instance, you know, hypotension correlates with sepsis. Hypertension correlates with, you know, renal perfusion. For in general terms, just maybe some things that you guys might see sometimes. Elevated ICP means brain swelling, and there's interventions that you can then implement to treat that. Mannitol, hypertonic saline, you know, hyperosmolar therapy is all of those different things. In the decades ago, they used urea. They would infuse the patients with urea. And I had an old professor who always complained, why'd they get rid of urea? Because it was so effective. Anyway.
You made mention on the blood pressure side. Because you're right, the hypotension, you know, we're familiar with that. We know exactly, yeah, we're going to do fluid boluses, maybe pressors, whatever. Hypertension, we've got our interventions for that. Can you maybe go over some of that interplay of heart rate and blood pressure when it relates to neurologic cases?
Yeah. So there is a correlation between ICP and blood pressure, and that is cerebral perfusion pressure. So cerebral perfusion pressure for a while was thought to be, I mean, kind of like things come and go out of what we practice, you know, the LDL is the good cholesterol. No, wait, the HDL is the good cholesterol. The LDL is the bad cholesterol. Things wax and wane. So for a while, the correlation between blood pressure and ICP is this cerebral perfusion pressure. It's MAP minus ICP equals cerebral perfusion pressure. And for a little while there, there was some studies that suggested that if you followed the CPP, you had better outcomes in brain injured patients. Well, so there's some normal values there. I can't remember if I included that on here. I actually don't think I got quite that detailed. Yeah, maybe I didn't. So the normal CPP, now I don't practice that. This is why it wasn't foremost on my mind, although there are certain circumstances where it might be appropriate to calculate the patient's cerebral perfusion pressure. The MAP minus the ICP. And there is, you know, so let's give an example. Let's have a patient who's got a MAP of 90 and their ICP is 20. So they've got a cerebral perfusion pressure of 70. What we have correlated is cerebral perfusion pressures less than 60 can portend worse outcomes. It's not that necessarily above 60 means you're going to have a good outcome, but below 60, there's some revisiting of this data that suggest, and more studies that suggest that at the very least below 60 is correlated with worse outcomes in brain injury. And again, this is mostly studied in brain injuries. Gunshot wounds, penetrating, non-penetrating brain injury. So the normal CPP is considered 60 to 70. Now, higher than 70 means that you're having more cerebral blood flow, means that that you're putting more stuff in the box. So the skull is a box, and it can only fit so much stuff. It's a fixed space. So the stuff it can fit include the blood, the CSF, and the brain. So there's a fine balance there that you have to strike, and that's where the blood pressure and the cerebral blood volume and the cerebral blood flow and all these things play together to help measure cerebral perfusion pressure, giving you an ICP. That's where it all comes from, obviously. So I'm sure y'all recognize that, but there are some tricky nuances to those things. And for a while they were studying things like the lactate levels and other electrolyte, other metabolic what's the word I'm looking for here? Byproducts, metabolic byproducts, lactate, pyruvate, stuff like that in these dialysis catheters that they would insert into the brain and trying to correlate outcomes with certain values of various things, pyruvate, lactate. They've done some things with jugular venous pressure, and tried to make devices that measure cerebral blood flow. So far, it's been fairly unsuccessful at getting good devices to reliably do that kind of thing. So the most reliable measure that we're stuck with that's most widely utilized, now there's some academic centers that are using these more advanced monitoring techniques, but they're also not as well proven. So ICP has been proven over decades of use to be a good correlation, and it's been studied at length to trickle down to places like Mary Lanning. So we'll use these kinds of things and ICP monitoring primarily if it ever even comes up. We have great imaging machines here that can give us good correlation too. So
then we'll just assume, for all intents and purposes, we probably won't be doing much ICP monitoring.
yeah.
Is there any way that we can then, as a bedside nurse, realizing that cerebral perfusion pressure is important, we can't calculate it, but is watching their vital signs, maybe we notice it creeping up in blood pressure, might that be an indication that the patient's body's trying to put more in the box potentially, and something we need to manage?
Yeah, well, for instance, So as when the body senses, so autoregulation is an important factor in your body regulating blood pressure and things like this. So if the brain senses that it's not getting enough blood, then it will increase your blood pressure. So patients that are having strokes, for instance, y'all have noticed that their blood pressures ride high on their own. Let's say a ruptured aneurysm patient. One of the problems that they experience is vasospasm, where the blood vessels become stenotic and it decreases blood flow, and the brain senses that, so it's going to increase your blood pressure, trying to open that. And one of the therapeutic responses that we've made decades ago is called hyperdynamic therapy, implementing as a response to vasospasm, actually driving blood pressures up in an aneurysm that's ruptured that has been secured. Of course, you wouldn't want to do that if the aneurysm hasn't been secured. We'll drive the blood pressure up, we'll hemodilute the patient to a degree and keep them hypervolemic. And this is a evolving, relatively simple interventional modality that can be used for it's very specific to ruptured aneurysms, for instance, and subarachnoid hemorrhages that can experience vasospasm. So yeah, the answer to your question is, when the brain senses that the blood supply is down, it raises your blood pressure.
Then, so for potentially notifying you, we probably come right back around to the neuro assessments again, right? Putting those data points together that here's what the DCS was, here's where it is now, here's a change in blood pressure and heart rate.
Yeah.
And then let you do the math and figure out.
Yeah, absolutely. That's right. And I might ask you, well, what was their motor score, on the GCS? So, that kind of thing.
Would you anticipate there might be times here that you would want us to have the patient be hypertensive for perfusion purposes based on what we're talking about then?
Not necessarily. Well, for a stroke,
Not typically.
Not typically,
TBIs
and not TBIs.
Okay.
No, not TBIs. Keeping them, because a TBI is going to be at risk for bleed.
Okay.
So, bleeding, and on here, I noted importantly, any brain trauma or like post-surgical patient or a patient that has intraparenchymal hemorrhage already, like a hypertensive hemorrhage or a hemorrhagic stroke or whatever you want to call it. There is a correlation between blood pressures above 140 and worsening of the bleed. So normotensive is what all the data has settled on, and that's a change in the last decade. It used to be, I think the value was 160 was what was thought to be acceptable. Now it's 140.
Okay.
And so that's why being normotensive is important in most cases. Now, we're not going to be doing aneurysms here. It would not be appropriate to bring those kinds of patients to a hospital like this. So strokes are a little different. As long as they haven't bled, you're trying to protect the penumbra. And now they are at risk for bleeding, though. So you get the hemorrhagic conversion. I don't know how often that happens here, but how many times y'all have seen that. Does that happen very often?
Either 0 or 1. It's a pretty low number.
Yeah, well, good. So, and despite the fact that their blood pressures are running in the 160s, 180s probably sometimes, I suppose. Yeah. So it's mostly isolated to those kinds of patients where you're trying to protect maybe a part of the brain that's been ischemic or something like that. Would we be wanting to have the blood pressure elevated? Otherwise, we're wanting it to be normal. So let's take that trauma patient, for instance. And so part of DAI is punctate hemorrhages. and microhemorrhages that sometimes you can't even see on a CT scan. You know, and as the correlation is made and studied that blood pressure above 140 risks increasing those bleeds. So even microhemorrhages are susceptible to that potentially, or we generally follow the guideline of being under 140 for any form of bleeding in the brain. So contusion, subdural hematoma, epidural hematoma, all of these necessitate normotension at least. An unsecured ruptured aneurysm would keep it even lower, in the 110s to 120s at the most, until at which point it can be secured. That blood pressure recommendation, I think, is in the guidelines that came out of the American Heart Association in 2007. So I put some other, you know, just to give you some of the normals. One of the things was, don't even know what a normal ICP would be. So normal ICP, we're all walking around mostly between 5 and 15. Up to 22. It used to be up to 20 was acceptable in a trauma patient. Now they've done some more correlative studies suggesting that it's safe to have a patient running it in the 22 range in some of the more recent studies, and Brain Trauma Foundation's guidelines that came out in 2016 reflect this as far as ICP goes. So normal is 5 to 15. Acceptable in a trauma, for instance, or a patient that's being monitored is, you know, if you're getting above 22, then we should all get worried on any regular basis. So if it hits 25, you know, for 5 or 10 minutes at a time, but then comes back to 15, that's fine. Let me know, especially if you want to.
Speaking of let you know, is there just like a base group of information that you want when we call beyond the normal vital signs set thing? And you know, obviously now probably adding in their GCS. You know, is there any other information that you want with every patient?
Too situationally specific.
Okay.
Or dependent.
Okay.
So, yeah, vital signs certainly, and if they've got an ICP monitor, then that'll be, if it's not something that you've told me, that'll be something I'll be asking. CSF drainage, you know, if we're doing that, if we're monitoring, if they've got a drain, and we're monitoring that, the output, you know, is good to report, that kind of thing. As far as clinical communication, it's gonna be patient specific, depends on what's going on with them in particular, I would say. But, you know, if we're monitoring ICP, then knowing that value at the same level that you would tell us about the blood pressure, you know, or if we're draining CSF, knowing that value, knowing what it's putting out either per hour or collectively since, you know, in the last 24 hours or something. But sometimes, for instance, let's say the patient has an EVD, an external ventricular drain, and they're draining, you know, 5 to 7 mils an hour, and in the ICU you're checking on them every hour, so you know pretty much what it's doing. Well, let's say suddenly it drains 30 milliliters in the matter of 10 minutes. Good to know. Call me about it. Doesn't always mean something bad is happening. Could be that the patient is waking up a little and coughed or something like that, engaged in some kind of Valsalva type maneuver, and the drain did its job by draining off some CSF.
Is there an expectation with neuro assessments? Everybody does them differently. Like, are you looking for pupil responses, nystagmus, and arm drift or strength, or?
Not specifically. Nope. But these values are good to have to follow. And when you note a change, like, you know, they used to have a 5 of 5 bicep strength, and now I'm noticing they're only 3 of 5. That's important to call on. So whatever it is that's alerting you to make a call, certainly that piece of information is good to communicate. But, you know, and then we'll just talk about the patient. Like, you know, one of the things, and I'm not down on this at all. For instance, let's say a patient who's awake and talking to you but has asymmetry, has anisocoria. Anisocoria means asymmetry in their pupils. Well, an anisocoria becomes certainly more important when the patient's obtunded or lethargic, or they've gone from awake and talking to you to in a coma. But if they're awake and talking to you and you notice their pupils on one side is 3 and on the other side is 2, what I'm trying to say is don't necessarily be alarmed. I'm not saying don't call me, but maybe for your own peace of mind, know that if a patient is awake and talking and there's an anisocoria, it's not too big a deal. I mean, depends on what's going on with the patient, though. Maybe they're having a stroke, and in a certain part of the brain that's causing an anisocoria. So important to note and important to record. But like in my, you know, I just did a laminectomy for decompression on a patient, decompression in their lumbar spine, and they're awake and talking, they're feeling good, and everything's fine. And anisocoria there is not such a big deal. There's normal conditions that cause anisocoria. Yeah, you know, right. They've got lenses or something. I mean, who knows? Addie's pupil is a normal variant that imparts a baseline anisocoria, for instance. So the overall volume of CSF in everybody's body is roughly 150 milliliters, give or take. We produce and reabsorb that total volume 3 times a day. So every hour you're making about 20 milliliters of CSF, 15 or 20 milliliters of CSF. And so that's when that becomes important if you're monitoring a drain, for instance. And, you know, you might notice an EVD might put out 300 milliliters in a day. Important to replace that 1-to-1 with normal saline, because if you're just removing all this CSF, they're going to become hyponatremic, because CSF is isotonic. So you have to replace it with a isotonic fluid.
In terms of coloration, I imagine, I have not done a brain drain in quite some time, but so post-op, would we expect it to, you know, have that blood tinge color to it, and then transition to a more clear color?
Depends.
What kind of things are we looking for in terms of that? If it's clear and it becomes pink, that's worth a call. Might not be concerning, might not be any big deal, but it's worth a call. And it depends on why the drain is there. Let's say we've done a cerebellar stroke or tumor or something like that, and we put an EVD in because the patient had hydrocephalus. Well, the EVD should be clear. The CSF should be clear. But if that turned bloody after operating back here, that's something worth noting. But if say it's a ventricular tumor, it might be pinkish for a while. You know, resected a ventricular tumor and we have a drain in there that's trying to prevent hydrocephalus. It might be pink for a while, and you'd expect it to gradually become clear. The normal color is clear. If it changes to yellow, that's worth a call.
Could be xanthochromia, could be infection.
We did have a little bit of a discussion earlier about drains. Did you girls want to ask some of those questions?
Why do you pick Hemovac over the JP drain?
Well, the JP drain was originally, it's a good question. The JP drain and the Blake drain were originally designed as subdural, to drain the subdural space. But it's widely used in other applications through general surgery and other things. The Hemovac, it's a rigid tube, it's a rigid perforated tubing that just slides out. So for ease of use and ease on the patient, sometimes there can be a little pinch that goes along with taking a JP drain out. But there isn't anything magic behind that, to be quite honest.
We were just kind of brainstorming, because I know there have been troubles with
Yeah.
drains getting pulled out, so we were just kind of
Yeah.
trying to, think of ways.
Yeah, the patients, it's usually a situation where the patient is trying to hoist themselves up in bed and they've grabbed the drain with their thumb and comes apart at the weakest link. It's just a matter of figuring out how to secure it in a way that the patient can grab it when they're moving around.
And we can certainly foam tape the whole length of the tubing down.
Yeah, I've thought of doing tegaderms in the OR before we leave or something like that. Probably tegaderm is just as good. I guess you could use a foam tape. Nothing wrong with that. I've thought about doing that, but then, then you've got this tape all over the patient,
Right.
and pulling that off becomes tricky sometimes, and I've seen patients, get a big abrasion from pulling the tape, and even tegaderm. Some patients' skin is so thin that, especially elderly patients, that their skin can go right with even a tegaderm. Tegaderms are typically gentler. Certainly seen of the tapes, the tegaderm's probably the gentlest. But, so, I'd like to try and avoid that if we can, but if that's what we have to do to keep these things from coming out on the floor, then we'll figure something out. Just, I think the drains is a matter of keeping track of the patient in a way that keeps that drain, I guess, in your mind. I think that it's a matter of losing sight or losing thought of the fact that there is a drain there is probably what leads to this. The Hemovac is a pretty common spine drain. I know the orthopods use it a lot too. I think it's because it comes out so easily. Once you're ready to discontinue it, it comes out so easily. Sometimes there's a concern that a JP drain could break at the transition from, it's just one tube, a Hemovac is just one tube that comes out. JP drain or a Blake drain or some of these other drains is the white part connected to the silastic part, and what could happen there. I've never seen that come apart, but I've heard about it. So then you've got a drain inside the patient. You've got that part of the drain inside the patient. The tubing's out, and now you've just created an operation to take out the rest of the drain. There's no good answer on any of it. And we touched on blood pressures a little bit, heart rates. It's the same in neurosurgery. Normal heart rate is normal for us as it is anybody else. But let's say the patient's hypertensive and bradycardic. You can have hypertension, bradycardia without changes in your respiration that is an indication of impending Cushing's triad. Is anybody familiar with Cushing's triad? Cushing's triad means the triad is hypertension, bradycardia, and a specific pattern of respirations. that is an indication of progressive herniation. So you can have impending Cushing's triad, which is kind of on its way to being a pretty dangerous situation for the patient. So you can recognize changes in blood pressure and heart rate, for instance, even before the change in respiration sometimes. So that's something to pay attention to. If you notice they're becoming hypertensive but their heart rate's real low and they're not responding to you, that's something to think about, something to pick up on.
What are some of the common causes that we might see here that could lead to that scenario? Just a couple of them off the top of your head.
Stroke. If a stroke is experiencing severe, say it was a very extensive stroke, and, like a holohemispheric stroke, for instance, or a big MCA territory stroke, you can get so much elevation of pressure on that one side that causes shift, and it's the shifting of brain structures that leads to the Cushing's triad. The blood pressure going up is a response of, hey, we've got, the pressure, so the ICP goes up that causes a decrease in the perfusion. And so the brain senses the decrease in perfusion, so it raises the blood pressure as a response to that. And the heart rate going down is partly a brainstem response that is suggestive of like a downward herniation, and so you're getting pressure on the brain stem itself that leads to the bradycardia. So it's an unopposed, vagus part of the heart rate and stuff.
While we're kind of on that
Sympathetic.
topic, I vaguely remember, is there a scenario where you could have, like, let's say, pressure increasing on the left side, and it's beginning that herniation process, and what winds up happening is the symptoms are reflective of maybe a right-sided stroke, that pressure is pushing on the far side of the skull, so even though the problem's on my left side, I might be having the symptoms of a right-sided stroke. Does that happen?
Yeah, it does. It's called Kernahan's notch, and that is a scenario where the shift has become profound enough that it's a very intricate question you asked on that.
Yeah.
But so the lining around the brain, comes down and forms a cuff, kind of around the brainstem. So that response is not pressure against the skull; it's pressure of your brainstem against the cuff of the dura that impedes the pyramidal tracts, the pyramids, so that when the signals come down from the brain, it comes down to the middle part, and then it crosses over before it goes down to your spinal cord. But it's the pressure, so you would expect a left-sided injury to cause right-side symptoms, but you've got a left-sided injury that's causing left-side symptoms. That is because it crosses before it goes against Kernahan's notch, and so the pressure causes the brainstem to pinch against that cuff of the dura that causes the opposite side to be symptomatic. Kernahan's notch. Y'all just learned a very
We'll see one of those next
advanced,
week, right?
I doubt it. It's a pretty advanced concept, but yeah.
I guess, speaking in generalities, we've had, in recovery, a couple cranies for brief amounts of time. And, I'm sure they go upstairs in different sorts of conditions, but for our world, I guess, how how sedated do you keep these patients, want these patients to be able to accurately assess their mentation?
A lot of patients, that's going to vary. Again, unfortunately, the answer is that it varies depending on the patient, what they had done, how long the surgery was, how much anesthesia they had. It can lead to some angst, even in me. A patient who, had something done and they're just not waking up too well, that can be normal.
Right.
And it's a function of the duration of anesthesia, what anesthesia was used, for instance. Sometimes let's say they used mostly IV anesthesia. That takes longer to come off than the volatile gaseous stuff, so you might expect a delay at times. So, yeah, that's not an easy thing. What I would say is if you're finding changes, something for you in the PACU that's changing in a way that makes you uneasy, or even if the patient's not waking up and you're just becoming uneasy, and then you say, well, let's all be uneasy together, because I didn't have answers for that either necessarily. Sometimes it's just gnash your teeth and write it out. Sometimes it might prompt a CT scan. I mean, depending on the circumstances, you might say, the patient should be awake by now. So for instance, we had a patient. This guy had I was doing an anterior cervical discectomy infusion, and before I even got to the discectomy part, the neuromonitoring guy said, "We've lost all signals. Have you?" He actually said, "Did you transect the spinal cord?" No, didn't transect the spinal cord. Hadn't even put my retractors in yet, but and whatever that was, I don't know if it was technical or not, but that guy kind of woke up a little bit longer from anesthesia. I mean, it could have been that there was actually something there. I don't know. TIA or who knows what happened to him. Everything came out. So we did some tests, right? Do you remember that case? Or maybe you weren't there for that case. But we did a head CT and we did some other things because it took him a little while to wake up, and I think we even MRI'd his C-spine from the recovery room. So everything was normal. The guy woke up, on the floor and was totally normal, and I chalked it up to technical error, technical problem.
I just think with neuro patients in general, stroke patients or whatever, it's a concern masking symptoms with pain medication or anti-anxiety medications or whatever the case is. It's just it's a concern that you're masking the restlessness. Could be someone having a stroke and you're giving them all this Ativan and masking what you should be paying attention to, just generally. And same in the recovery room with anesthesia and pain medications and everything. So
Yeah.
Don't want to overdo.
Yeah. Just call. We'll worry together. And figure out how to sort it out.
On that note, what kind of guides your decision-making process on going to the medical surgical floor versus progressive care or ICU? Now that we've had a year to kind of practice things out and you've seen how we've worked, what's some of those things that help you decide one direction or another?
Trying to think. I sent a guy to the PCU the other day, but it's escaping me why. Oh yeah, that's right. Yeah. It was a pretty routine operation, but we had, in the course of retracting his IVC, he got a little pinhole in the underside of the vena cava being raked across an osteophyte. And so wasn't really anything to do with it, but kind of sealed it off, which it sealed itself fine. It wasn't a problem at all. But that was concerning, that if that broke loose, he would need a little bit more than Q4-hour monitoring, for instance. So that's what led to that as an example. Cranies, one of my partners in Georgia, for instance, sent all of his posterior cervical decompressions to the ICU afterwards. To me, I never experienced any problems. We're all colored by our experiences, though, of course. So he probably had a patient at some point that had a bad outcome for some reason. And so from that point forward, he always sent them to the ICU for close Q1-hour monitoring. I haven't had that experience, so they've done well. A cranie is going to be routine to go to the ICU. And depending on the comfort level of the staff, in Georgia, for instance, even though it was a pretty high-level neuro facility, the staff still had their little, they weren't as comfortable or experienced on the floor, for instance, with some of these higher level patients, so we'd keep them in the ICU maybe a little bit longer. In Denver, where I trained, there wasn't a single cranie patient that would stay in the ICU more than one day, because the floor nurses just, it's a neuro program and we're doing lots of high-level stuff, so the neuro ward team was as comfortable as the ICU nurses with all that stuff. So otherwise, the goal is to get them to the ward as soon as possible out of the ICU on a cranie.
So fun, silly question. Bit of a nomenclature thing. Ward, ICU, PCU. Is ward kind of basically med-surg in your mind, like a general ward?
Yeah.
Okay.
Floor.
Yeah.
Ward.
It comes up every now and again.
I don't know how I
Good
was
chance to say.
somehow trained that way, but then someone later told me that's the old way of saying it. I don't know.
Well, we have a psych facility. Some of us are like, psych ward?
Ward used to mean the floor, I guess. I was always taught that ICU is the ICU and the ward is the floor, and yeah. I think we've covered all the important stuff on the list, at least.
So are the cranies usually, do they go up intubated most of the time?
No,
No.
not an elective cranie. They will never, as far as I'm concerned. They'll leave the OR the same way they came into the OR for an elective patient. And that really goes for the majority of patients. If they go into the OR, they're probably coming out of the OR intubated. But if they go into the OR, not intubated, then they should come out of the OR not intubated. But if we're moving so fast from the ER to the OR, on a bad subdural, for instance, then maybe. But that doesn't happen. It's not going to happen that much here. Yeah, I believe that probably comes down to how you're trained. Referring back to one of my partners in Georgia, he would keep some of his elective cranies intubated after operations. I was trained, that we never did. So it's always something you should be able to take the breathing tube out. Come out of the OR the same way they came in, for the most part, with only very few exceptions. All right. Well, we'll have these every week, so if there's burning questions that come up, again, we can talk about it next time. I thought that I would bring some papers to talk about next time. Some And we'd have a discussion maybe about that trauma patient that came through here that was a little contentious about how to treat that patient's respiratory status. I'd give my perspective on that next time, and I'm sure you guys know everybody else's perspective. So
Well, thank you very much, Dr. Bell, for your time.
you're welcome, y'all.
Thank you.
Anything y'all want to hear specifically that we can do moving forward?
I think one of the other ones that we can discuss at next time is attending versus consulting service, and what kind of expectations we might have, if that's going to vary whether you're the primary on the case or not. Of course, it's going to depend on what the problem is as well. But there's been some questions about that, so we can discuss that next
Okay. Yeah, absolutely.
And yeah, maybe talk into orders a little bit. It sounds like they're going to be pretty, a la carte and tailored, but maybe a chance to go through one or two scenarios of
Sure.
what types of orders to expect in general.
Yeah, well, I mean, I've got 2 order sets that I use, a cranie and a spine. And it's not going to vary much, but for instance, just this lady just now had wet toilet paper for dura, so she got a CSF leak during the course of her operation, which isn't normal, but I modified that normal laminectomy course to include some bed rest for a little while. So, stuff like that. But for the most part, the orders are pretty routine. You're going to be pretty much the same, but scenario based, like this lady, for instance. For the most part, cranies are going to be the same. Head of bed elevated, blood pressure controlled under 140, stuff like that.
So then
But yeah.
For the TBI world, would we probably anticipate that being very similar to the cranie order set then, just as a general rule?
Yeah. Yeah, quite a bit. I mean, it depends on, but there's more nuances to it, like respiratory status and are they intubated, are they extubated, when to extubate. It's another point on that patient that was source of some disagreement on practice. I mean, just a difference in practice.
But we'll save it for next week.
Yeah.
Do you ever anticipate doing any bedside procedure, or will everything pretty much, other than drain removal, happen in a surgical suite? Do you have a preference?
There's some, like those SEPS drains,
Right.
and we've already done that a couple times on the ICU.
Okay.
That's pretty much it. I like to put so an EVD can be put in at bedside, but I like to make my burr hole a certain way. So I actually like doing that better in the OR.
Okay.
And usually it doesn't. I mean, it happens infrequently enough that it's not going to lead to any major delay in the patient's care or anything. So,
Okay.
I mean, it might occur where that needs to be done emergently.
Then
And if that-
you would anticipate that we need to train for specifically, other than ASEPs, and make sure we have ability to run an EVD.
Yeah. Yeah, exactly.
And then basic assessments.
Yeah, and I mean, as far as situationally, no. I mean, and the good thing about those procedures is, as a bedside procedure, they all come with kits that have everything in it,
Right.
including 4x4s and, the whole 9 yards in one box. So,
Okay.
knowing which box to grab is probably the only thing. And I'll help. I'll tell you which one.
Thanks much, everyone.
Thanks for coming, y'all.